after sustaining injury to the elbow, was subjected to a local practitioner who performed what he knew was massage and repeated splinting, which has resulted in a frictional injury to the muscle, leading to heterotopic ossification of that muscle into a bone myositis ossificans lesion has been created. So by this time, you already are aware that myositis ossificans is the answer for that question, or the question we are talking about is a myositis ossificans related question. Next, when the child was subjected to an orthopedic practitioner, he has to decide the management now. So what he did, he got the ESR done. Now ESR was found to be elevated. Now what next? What you will do? Immobilization and NSAID. So surgical correction, obviously not, because it will further invite the inflammatory process. You will never incise an active lesion. Elbow physiotherapy, you see, this is the time where if you go for elbow physiotherapy, then there will be more vascularization, more inflammatory tissue will be created, more injury to the muscle which is already injured or under the activity of myositis will be exaggerated. So elbow physiotherapy is also avoided at this time. Immobilization with NSAIDs is obviously the answer for that particular question. Register a case, no need. It is just for the fulfilling of the options, although this should never be provided to you in the option. You just have to go with the answer of immobilization and non-steroidal anti-inflammatory drugs in case of active lesion, while in case of latent lesion, you have to go for surgical correction or surgical removal of that. Hopefully everything is clear related to this myositis ossificans. You know, there are two types of myositis ossificans lesion. All these things you need not to go into the details of. Everything the question is going to be asked is going to be kept practically in relation to the supracondylar fractures of the humerus more commonly. All right. Next topic is pathological fractures. Now, first of all, try to understand what is pathological fracture, because fracture in the bone is a pathology for the patient. So, fracture in itself is a pathology. What is pathological fracture then? Imagine if this is a bone, and in this bone there is a lytic lesion. All right, there is some tumor which is present inside this bone. Now, the presence of this lytic lesion, presence of this tumor in the bone, is it not going to create a weak segment in this section of the bone? Yes, and this weak segment is likely to get fractured. It is very easily fractured. So, if a bone is pathologically affected, which has resulted in an easy fracture of the bone, is known by the name of pathological fracture. Hopefully, you have understood what is pathological fracture. As far as etiologies are concerned, that means causes are concerned. So, as I told you, any cause might result in a pathological fracture, but the most common cause for the pathological fractures to happen is osteoporosis, where the bones are porous, all right, which leads to a pathological fracture. That is considered to be a most common cause. Otherwise, every tumor, any metabolic condition, any infection to the bone might result in a pathological fracture. But the most common one is osteoporosis, a metabolic condition. Then, what are the most common sites where you can see these pathological fractures? The most common site is the thoracolumbar region. You see, thoracolumbar is the most common site because there will be a compression of multiple vertebrae, particularly in case of osteoporosis. Then second most common site is neck of femur, fracture neck of femur. Then the third most common site is the fracture distal radius. All right. So these are the commoner sites where you can see these pathological fractures happening. All right. Now, there is a criteria which is not used for making the diagnosis of pathological fractures. There is a criteria which will decide that whether to fix the pathological fracture prophylactically or not, or pathological bone prophylactically or not. So first of all, you have to write down the name of this criteria. The name of the criteria is Mirrell, and Mirrell criteria simply is for prophylactic fixation of pathological bones. Now, what does it mean? What does it mean that you have to fix the bone before they get fractured? All right. Imagine it is the kind of a score which is not used for the diagnosis of pathological fracture, point number one, because most of the time we tend to think that, Merrill criteria is something that we are studying under pathological fracture. So Merrill criteria is a diagnostic criteria for pathological fracture. No, it is a criteria whether to go for fixation or not. All right. So how will you decide whether to go for fixation or not? Now, based on that, Merrill criteria actually, for example, if we take this, that there are several variables which are taken into account, like site, pain, lesion and size. So imagine if the size of the lesion is involving less than 1/3, then 1/3 to 2/3 or more than 2/3 of the horizontal surface of the bone. So the greater score will be provided to this. So greater the chances that this bone might get pathologically fractured. Before the bone gets fractured, you have to fix it before. All right. Before even the fracture happens, you are fixing it before the fracture. So for that, we are having a Merrill criteria. So the criteria is not for pathological, but for prophylactic fixation of a pathological bone. Hope everything is clear related to this topic also. When we were talking about the introductory part of the orthopedics, we have written one line that transverse fractures commonly are pathological fracture, or other way around, if you reciprocate the statement, that pathological fractures commonly are the transverse fracture. Now you can very easily understand that because the weak section of the bone, when it is subjected to an indirect trauma also, it can be easily broken, and that indirect trauma results in a transverse fracture commonly. That is why pathological fractures commonly are transverse fracture. This is something which we have already written. So hope everything is clear related to these particular topics, like we have talked about compartment syndrome, fat embolism, then the stress fracture, and now the pathological fractures. Now, there are two complications which are related to union. Just try to understand. Before we talk about these complications, it is important to have a discussion on what are the two possible complications related to union. All right. So, complications related to union at the fracture site. All right. What we are talking about, if the bone got fractured, then it can have three outcomes in the form of a complication related to the union at that fracture site. So one of the complication is non-union. Non-union means there is no union at all. The bone has failed to unite. The fracture has failed to unite. That is non-union. Second is malunion. Malunion means that the bone has united, but it has united in an improper way. All right. Before the fracture, it was a straight line like this. Now we are having a step. There is a resultant deformity. There is a resultant angulation at the fracture site, but it has united. That is malunion. So you came to know the clear-cut differences in between the two, that in case of non-union, there is no union. Malunion, bone has united, but in an improper way. And the third one is delayed union. That the bone is uniting, but it is uniting at a very, very gradual pace, very slow pace. That is delayed union. So no question is directly going to be asked in relation to this delayed union. It is important for you to identify what is non-union and what is malunion in the form of a complication. So non-union and malunion, these are the two headings for you. Now, as far as the reasons for these non-union and malunion are concerned, the reason is inadequate. You see, if there is inadequate immobilization at the fracture site, that means the fracture is persistently allowed to be to move, then the possibility of union will be hindered, and this is considered to be the most common reason for the fractures to go into non-union: persistent immobilization or inadequate immobilization. Second is inadequate contact or reduction. Imagine if the two bony fragments are not even coming in contact with each other, then it might result in non-union. Inadequate vascularity. For any bone to unite, vascular, periosteum and soft tissue coverage has to be adequate. So if there is no vascularity, soft tissue coverage or periosteum present, then the possibility of this bone going into non-union will be very high. And finally, a diseased bone, a bone which is already diseased, not having adequate osteoblastic and clastic equilibrated activity. All right. So it might result in non-union. Now, as far as malunion are concerned, it is imperfect reduction is considered to be the only reason. That if the bone was like this before the fracture and it got contacted like this after the fracture, and here itself the bone united, so it will result in a malunion. So imperfect reduction is the basic reason, basic cause for this malunion. But one thing that you have to remember in future, if I give you this bone, sort of a bone, like this is a bone, all right, and this is the cortical region of the bone. This is cortical, and this is the cancellous region of the bone. Now, because the cancellous region of the bone is more vascular, cancellous region is a spongy region of the bone where the porosity of the bone is higher, where the per unit area is more vascular in comparison to the compact bone, because compact bone is more densely packed. So, cancellous bone is more vascular, and because of this increased vascularity, it will aid in the union. So, what in future you have to remember, that every time you see a fracture in the cancellous region, that means fracture in the metaphyseal region, the higher the chances of malunion as a complication in comparison to non-union. So, in cancellous or metaphyseal fractures, suppose I give you a fracture which is cancellous, a fracture which is occurring in a metaphyseal zone, and then I'm asking you that which of the two complication would be higher the chances of which of the two complication, malunion or non-union as a complication of union, then you have to go with the answer of malunion. Cancellous or the metaphyseal bone, they tend to unite more because of increased vascularity, but if there is a imperfect reduction that has happened, it will result in a malunion. All right. So, in future, you will realize what is the importance of this particular topic.